much for your coming.
Thank you, Claudio. It's great to start early, in part so that we can all get to dinner faster. It's very uncommon for the last talk of the day to be starting early, so that's fortunate for all of you and hopefully for me too. It may also give us some additional time to focus on this issue, because certainly as I attend symposiums and conferences around the world and look at the programs, there's much more attention being paid to this subset of patients, and I would predict going forward that they will be identified as a separate stage and a separate group of patients for whom we need different therapeutic strategies. What I'd like to do in the context of 20 minutes or so is to look at the pretreatment radiologic classification system that we and others use, and use that as a springboard or a jumping off point to look at what we define as borderline resectable disease, because so much of this centers around the definitions and in particular the interpretation of the CT scans. Then I'll share with you the therapeutic strategy that we've used at MD Anderson to approach this patient population. We've done so in a prospective way, and I'll share with you our treatment results. And hopefully this will help to crystallize some of the thinking and provide a platform for good discussion. The criteria that I think most in the room use to evaluate patients for resectability are really based on the local anatomic relationship of the tumor to these critical vascular structures that I've listed in the left-hand column. And I think resectable disease is easy for us to define because there's clearly no involvement of any of these important vascular structures, and there's no thrombosis or occlusion of the superior mesenteric vein. On the far right, encasement of the SMA or other vascular structures is basically the sine qua non for locally advanced disease. And in the middle, we have what we're calling borderline resectable disease, which is really not really easily resectable, or in many people's interpretation, they classify these patients as unequivocally unresectable, but not really completely locally advanced if we look at the scans together. So what we're talking about there is abutment of the SMA so that the tumor is up against the lateral surface of the SMA in one or two slices, but not encasing, not completely around the artery. Or we're talking about, in some situations, of short segment abutment of the hepatic artery, usually at the origin of the gastroduodenal artery. In the venous situation, we're talking about short segment venous occlusion, where there's tumor-associated venous occlusion, but there's a patent segment of portal vein above and superior mesenteric vein below the area of occlusion. And we've sometimes applied a simplistic classification system of type 1A/B, type 2 and type 3, and I'll show you some of these scans to help us see what we're talking about. Here's a case, I think, of fairly straightforward resectable disease. The critical factors that experienced surgeons look at for the trainees that may be here in the room relates to the relationship of the medial edge of the tumor versus the lateral surface of these important vascular structures, the superior mesenteric vein outlined here and the SMA. And as we heard earlier today, what we're looking for here is a normal soft tissue plane along the lateral surface of these vessels, indicating that there's a safe and navigable tissue plane along the SMA, for example, which can be traversed without risk for encountering tumor. We also see situations that are resectable, but when we look closely at the scans, we can see they are likely to require venous resection. And that's illustrated here. You see the low-density tumor in the pancreatic head, the stent situated in the bile duct, the SMV outlined here. And as you look at this, you can see that there's involvement of perhaps 25% of the circumference of the SMV at the level that the epicloic vein and the venous trunk of Henle pass into the vein at this level. And you can look at this scan and see that there's no involvement of the SMA. If we look at the SMA out here, in fact, there's quite a nice margin on the SMA, But without question, there's a high probability that an operation for this patient will require a technical strategy to deal with this segment of venous involvement. Over here we have a slightly larger tumor outlined here, and you can see again that the tumor is away from the SMA. Here's the SMA right here. This is the SMV, and this is the first jejunal branch of the SMV, which passes posterior to the SMA in about 80% of patients. And you can see that in some, one way to look at this specific scan is that this first jejunal branch has effectively functioned as a biologic barrier preventing progression of the tumor medially. But you can also see that this is going to also be a very difficult operation. To resect this tumor, we're going to have to divide this vein, probably on this side of the SMA. This vein is going to have to be divided, and there'll be a more complicated reconstruction required to facilitate resection of this. And as we heard earlier, this can be done by end-to-end anastomosis. The technique that we and others have used is interposition grafting, in this case, a segment of internal jugular vein that we use. And you see the dissection plane that we and others use, which is along the right lateral surface of the superior mesenteric artery with direct identification and ligation of the arterial branches as outlined here. Now here's a case of more straightforward, locally advanced disease where we can see there's involvement of the majority of the posterior surface of the SMV by a larger low-density tumor, and we have substantial involvement exceeding 180 degrees of the SMA. This is a patient who should not go to the operating room. We can make that assessment on the basis of this scan. And the older concepts that historically many surgeons were trained with exploratory laparotomy and attempted resection are not needed in the context of the high-quality CT scanning that most of us have available now. So here's an example of what we're talking about when we're referring to borderline resectable disease. Here's a small tumor, rather poorly located in the inferior pancreatic head or uncinate process. You see the SMA outlined here. You see the inferior pancreatico-duodenal artery outlined here, and we see the low-density tumor comes right to about here on the top side and comes around the back right to about here. There's close to 180-degree involvement of this, and we clearly have a problem here at the origin of the IPDA. So if we were to look at this, the terminology that we use for anatomic classification, as we published some time ago now, includes SMA abutment of less than or equal to 180 degrees, celiac axis abutment, segmental common hepatic artery abutment or encasement, and segmental occlusion of the SMV and portal vein with options for reconstruction above and below. So let's look at some scans together so that we can see exactly what we're talking about when we're referring to borderline resectable disease. Here's a case similar to the one I showed a moment ago. We see the low-density tumor outlined here, a wall stent in place. You see the tumor extending up to the lateral surface of the SMA, and we see something less than 180-degree involvement. Here's an example of celiac axis abutment. We see a small tumor, but look how poorly located this is, right at the, really at the bifurcation. And we see the common hepatic artery here and the splenic artery here. This is clearly a very difficult situation and probably not a case that most surgeons in the room would like to go to the operating room with immediately on Monday. Here we see the common hepatic artery encasement. If you look at the low-density tumor outlined here, situated really right on the surface of the portal vein, you see the artery running right through the tumor at this level. We don't have the entire scan here, but if we did, you could see that there's free artery above and viable, workable artery at the origin of the hepatic artery. But you can see that we've got clearly a significant arterial problem at the mid-segment of the common hepatic artery at the origin of the GDA. Now, if we look at a case of SMV or portal vein occlusion, what I'm going to show you are a series of images from this patient's scan. You see outlined here the portal vein high up above the level of the pancreas, and as we scroll down, you see the confluence of the splenic vein and the superior mesenteric vein. The artery is not a problem, it's outlined here. As we go down, the tumor starts to come into view, and we can see appearing the larger tumor. We see the degree of venous narrowing that's now present at this level. And at this point, we see complete occlusion of the vein, and we can see venous collaterals around the tumor at this level. When we go another image or two lower, we see a nice patent SMV below the tumor that appears of reasonable size, caliber, and patency suitable for reconstruction, but the bigger problem is above that, where there's substantial involvement and occlusion of the vein. These are clearly cases, if we look at this spectrum of anatomically borderline cases, where most surgeons in the room would not be wildly enthusiastic about going to the operating room on Monday to try to resect these patients, and certainly if we were to do so, we would not be going to the operating room with any expectation of an R0 resection. So if we look at the rationale that we've used in our institution for preoperative treatment of these patients, here are the main reasons that we've used this approach. We'd like to facilitate margin sterilization in order to enable R0 resection, and I'll show you a more graphic cartoon to illustrate that point in a moment. Certainly, in many of these cases, we'd like to see some type of treatment-related response. We'd like the tumor to get a little bit smaller, or in some cases, perhaps to pull away from some critical anatomic structure. And as is often the case, and as I'll illustrate in a little more detail tomorrow, this treatment approach, the use of preoperative treatment that necessarily delays an operation for patients like this, improves patient selection for surgery in a setting where we can all acknowledge that we're looking at very technically difficult operations that carry, in all probability, increased risk for morbidity and possibly mortality. So here's the therapeutic approach that we've used at MD Anderson for these patients. They undergo initial staging by multi-phase multiplanar CT. And then in our pancreas planning conference, they are classified prospectively on the basis of anatomic criteria or sometimes on the basis of performance status, and I'll come back to that point in a moment, as having what we define as borderline resectable disease. We then treat those patients with a program of induction chemotherapy, usually using gemcitabine treatment. They then undergo restaging. At the time of restaging, we will identify some patients who have progression of disease, usually apparent in the setting of radiologically definable disease in liver. Those patients then drop out of this treatment program and get treated for metastatic pancreatic cancer. They're also spared the morbidity associated with radiation treatment. The group that appears to have responding or stable disease at the time of this CT scan then undergoes treatment by chemoradiation treatment. That is then in turn followed by approximately a 6-week break. Then the patients undergo restaging. At the time of restaging, we present the case once again at our multidisciplinary planning conference. And in that setting, with interdisciplinary discussion and review of the scans with multiple surgeons and assessment by the primary surgeon and oncologist, we make decisions about whether patients should proceed to the operating room for attempted resection or not. We also identify at the time of that scan another subgroup of patients who drop out because these patients have had, again, progression of underlying biologically aggressive disease that becomes manifest during this period of preoperative treatment. So if we look at what we're trying to accomplish with respect to the margin and the way in which this approach might help us to achieve an R0 resection, you see this cartoon that outlines the anatomic problem that I portrayed on the CT scans. And we can see that in a setting where upfront surgery would be performed, even if we're choosing a correct dissection plane right along the lateral surface of the SMA, we're at high risk of encountering a positive surgical margin. And we can show that an R1 resection in almost all circumstances is not a curative procedure for these patients. In contrast, if we were to administer chemoradiation treatment to what we know and understand is a well-vascularized rim of tumor at the periphery of the tumor, then our goal would be to try to achieve this, some type of decrease in the size of the tumor and sterilization of this non-viable rim of tumor so that when an operation is performed, we can achieve a negative surgical margin. That's the theory behind this therapeutic strategy. Now, earlier I alluded to the different classes of borderline patients that we have in our interdisciplinary planning conference. The group that we've been talking about primarily this evening has been what we call our type A borderline patients, who are classified as borderline resectable on the basis of anatomic criteria. We also have two other groups. There's a group, let me go backwards. If I can go backwards. It's good to have help. Okay, so there's a group that has what we call indeterminate extrapancreatic metastatic disease. What we're talking about there are the patient who has tiny, low-volume lesions in the liver, and you and the radiologist are looking at them, and you're really not sure whether those are metastases or not. In most circumstances, they are, but you can't be sure based on anatomic criteria. And then there's the type C patient who has a marginal performance status. That's the type of patient whom you look at in the clinic, and as you look at the patient, you're really uncomfortable about whether that patient can undergo this operation. In those patients, this type of a treatment approach serves, in essence, as an oncologic stress test. If they can get through chemotherapy and chemoradiation treatment, they can probably undergo a Whipple procedure. So we recently looked at our experience with 160 patients who were classified as having borderline resectable disease on the basis of the criteria that I showed you. They were treated according to the treatment approach that I outlined, and you can see that of the 160, we had dropout of 35 for these reasons, including disease progression. We had patients who experienced early death related to disease and a small group that was lost to follow-up. In contrast, 125 of the 160 completed all components of treatment. And again, that shows you the ability to deliver this type of intensive treatment when it's given before an operation. If you try to give this type of treatment after a Whipple operation, most patients cannot undergo chemotherapy and chemoradiation treatment, and we see a high dropout rates when that's superimposed on major surgery. 82 of the 125 were considered potentially operable. 79 went to the operating room, and 66 were ultimately resected. The 43 at the time of secondary interdisciplinary assessment were felt not to be operable on the basis of anatomic criteria, or in the case of suboptimal, inappropriate performance status. Now, if we look at the subset that presented with borderline disease, and we look at the preoperative, perioperative factors associated with surgery in the 66 that we did surgery in, we can see, as we had talked about earlier today, that a number of these patients came to our center having had attempted resection at another institution. We also see the duration of treatment, where we're talking about a median of 15 weeks of treatment before operation. And you see the biochemical response that's achievable if we use CA19-9 as a surrogate for biologic response. You see the median value pre-treatment of 218 and a preoperative value of 40 achievable in these patients, and we have the data stratified by borderline type here. If we look at the operative factors as outlined here, as you would anticipate for this group, there's a high vascular resection rate, but in spite of the complexity of the surgery, these patients have a length of stay that's similar to other patients undergoing this operation at our institution. Perhaps the most interesting data come from a careful analysis of the histopathologic data from these patients. And before presenting this data, I should perhaps explain to you the approach that we use for margin assessment in our hospital. At the time the specimen is removed, the surgeons then take the specimen to the pathology suite, which is located in our surgical suite. We sit down at the bench with the pathologist, and the surgeon applies the ink to the specimen so that I can ensure that the margins that are reported out are accurate. This is because in our hospital, we have 60 pathologists, and out of the 60 pathologists that rotate through our surgical pathology suite, there's probably only one of them that I have confidence can accurately orient and correctly ink a Whipple specimen. So we, for quality control and data quality reasons, apply the ink to the specimen ourselves, and then we ask our pathologists to report out the distance from tumor to the inked margin on every pathology report, which is formatted using a synoptic design that we alluded to earlier. Now, with that in mind, if you look at this group of borderline patients, you can see our R0 resection rate of 94%. In the group that we've been speaking about chiefly, the anatomically borderline group, we see that 31 out of 32 patients with anatomically borderline disease underwent resection with negative margins, providing at least single institution support for the therapeutic approach in the cartoon that I showed you earlier, outlining the principle of margin sterilization. If we look further at the outcome data of these patients, and we look at the Kaplan-Meier survival plots for the entire borderline group or for the subsets, what we see in this context is a median survival of 40 months, again, as compared to the numbers you saw earlier today of median survivals of 20 months for patients who have localized earlier stage pancreatic cancer. So in summary, if we look at some of the critical data from our institutional experience of prospectively treated patients, we see that overall there is a subset of patients who appear to have locally advanced disease who may be termed unresectable in other locations that can undergo successful resection and can do so with a high probability of achieving a potentially curative resection. That's supported by the follow-up data where we see median survivals, again, of 40 months in this patient population. So to summarize, what we could say is that there may be a subgroup of patients who were previously felt in many centers to be unresectable, who may be better described by us as oncologists as borderline resectable. The criteria that we use for classification of these patients includes anatomic criteria, criteria related to disease progression that cannot be definitively determined, and criteria related to performance status and the ability of a patient to undergo an operation of the magnitude that we're talking about. We see that the data, at least from this single institution experience, suggests that borderline resectable patients can be managed initially with preoperative treatment in order to select a subpopulation of patients for whom surgery might be expected to have favorable results. And I'll stop there. I thank you very much for your attention.